let's look at some shaft fractures. Now this is a proximal phalangeal shaft fracture. Now this is unstable and it's impossible to hitch reliably. Transverse, short obliques and comminuted fractures will fall into this group. Because they can't be hitched properly, you have to stabilize them. So when you need to stabilize them, I prefer to use just one single K wire. And usually for doing that, you need to push up, as seen here on the right side, to push up the base of the proximal phalanx. You can actually feel the entire base of the proximal phalanx. Even if there is edema, you can displace the edema and you can feel this. Once you've done that, use a good wire driver, and by the side of the extensor tendon, you pass this wire in. Obviously, you're going through the extensor hood. So you don't want to keep that in extension. You want to hold that in flexion, and you need the flexion to push up the base of the proximal phalanx. So you hold it in flexion at the MP joint and you pass that. One wire is good enough, mostly, because what is your aim? It's to prevent the slipping off. There's no need to fill the medullary canal as has been done many, many times. And the bouquet technique gives you absolute stability, yes. But if you're going to strap it to an adjacent stable digit and mobilize it, you don't need to fill up the medullary canal. And you can get good results with no extensor lag. What if multiple such phalanges are involved? Well, then you do the same thing for multiple such phalanges. And here, if you have an unstable segment like you can see in the middle one, then you may have to add the number of wires. So you can add the number of wires. Now, will this cause, now you pierced the extensor hood at 4 places at different parts. Will that cause extensor lag? It need not. If you followed the principles of what I was talking about, it need not have any lag at all. And you can see the scar marks, the pins have just come off. Let's now go on to the middle phalanx and let's see the more difficult ones. This is a difficult one for wiring. And if you want to open it, you need to know the anatomy, you need to have fine instruments, you need to have a lot of training, it could be comminuted. So this is a difficult fracture to treat. So what do you do for this? You need to just put it back into place and put 2 thin K wires inside. Now, here's a patient whose similar fracture on the thumb is being treated. What you need to do is to first hyperextend and slip the head fragment and the head and neck fragment back into place. Then you need to put on 3-point pressure. And the 3 points of pressure are on the shaft of this bone, on the neck of the bone, so that you're pushing it down. And the third, you shouldn't forget to flex the IP joint here in the thumb so that the EPL will tamp down the fracture when you're passing the wire. And then you pass in your wires, and these are the correct size of wires that you need to pass. And you can see a perfectly well reduced and well held, and the joints not being involved, and therefore the movements are going to start right away. What you should do for doing this, you need to be a little careful. So here's a similar fracture. There's the reduction being done. So you milk it back into place after hyperextending it. Once you're sure, then you hold the MP joint, the IP joint in flexion. And then you take a wire driver and you drive the wire in. Here's a striker drill, it's not a wire driver. And you check on the C-arm and you pass the wire in. Stop and start, don't continuously drill. When you cross the fracture line, go in carefully and stop at that point. The second wire is usually a thinner wire, and once you come to the opposite cortex, you only oscillate in your hand and push it in, and you can see how it takes the shape of the shaft and goes in. Then you can advance it a little with the drill. Then you cut and bend the wires. I don't keep any wires outside. I always push them under the skin, and I need to give a little local anesthetic to remove them with a small nick. It gives you much lesser chances of infection and irritation with soft tissues. Some of them will obviously give you trouble, but not all of them. Leaving them out, you're inviting a lot of reaction and redness and sometimes infection. There was an old paper which spoke about 16% less infection in wires that were buried. There are very few papers with this effect, but that's how you would normally do this. Now, if it's a small fragment, it's difficult to control and it's an unstable fragment. What are the tricks in trying to get them in? So what you could do is pass an axial wire if the head and neck are facing the distal phalanx. And once you've got control over that fragment, you can bring that into reduction and then pass your crossed wires. And then remove the transarticular wire. Don't forget, remove the transarticular wire. What if it is not facing where it should? So here's 90 degrees. So the joint is completely flexed if you look at it. So then you pass the wire at a different place. So what is done here is passed transversely straight down into the head and neck, and then it is manipulated slowly to bring the wire, to bring the head and neck in position, and then you proceed to fix it down with crossed wires. So you don't need to open these. They look like you will 100% need to open them, but you really don't need to do that. Terminal phalanges, very rare indication for fixation would be when it's a compound injury, but most of the others you do not need to fix them. If they are compound, then obviously you need to fix them. Simplest thing is to use a simple intermedullary wire, and you should get fairly good function in these cases. Looking at the neck fracture here, this is like a boxer's fracture. This is on the index finger, and the angulation. I showed you one where I conserved it despite the 30-35 degrees in the little finger and the ring finger. We were able to get a good function, but in the index finger, it won't tolerate 35-40 degrees. It will tolerate 15 to 20 degrees. So you need to flip this back into position. Now, if you pass retrograde wires from the head and neck, it's going to be a little difficult. So what you need to do, it will stick the gliding tissues in that position. So what you need to do is to pass an antigrade wire with a pre-bent wire, and use a T handle to push it in. And once you go in from the base of the metacarpal, after drilling a hole, once you go in, let the bend be along the flexion, and then you rotate. So you can see that happening. You rotate, and you see the rod, the K wire actually flipping the fragment back into place so that you can get a good result. What if multiple such fractures are there? You can do the same from the ring and the middle and in the index finger, and you can hold them up and get a good result. Remember, when you come towards the middle two metacarpals, you have the fourth extensor compartment tendons over there. So you can't actually, it's not a very clear area for you to do this. So you might then think in terms of doing some other technique of fixation, like plating of multiple screws. Looking at shaft fractures like this in the middle phalanx, what you see is there is a gap, and what you need to do is to reduce that gap. So if you reduce the gap, you need to hold that position. You can pin it down with 2 screws or with 2 K wires and get a good result. When you see this, it's well aligned, but if you look at the joint, it's not stacked up properly, and you can see the air gap just beneath that joint, and that air gap tells you there's rotation. Obviously, this is what it's looking like. Once you reduced it, hitched it back, fixed it with 2 wires, you get good results. So you've got to close the rotational problem. At times, you're faced with fractures like this. You're tempted to put in a plate, but you could plate this again with a wire. It's a comminuted fracture, and temporarily you can impale a wire from a safer area on the dorsum from the side of the extensor tendon, so that you keep this in position while you mobilize the patient. It will go on to heal very well. You remove that first wire earlier, and you can get a good result in that as well. Shouldn't you be using screws? Yes, of course. If you have the screws, if you have the training, if you know the anatomy inside, use screws. But you must use the principles of screws. Don't put screws where they cannot go or where they are not going to function well. So you must use these screws well. And here's a case in point. And this is a metacarpal fracture, which is a long oblique fracture. It's not a spiral fracture. That's the reduction, and it's quite clearly an oblique fracture with multiple screws in position, and that looks very well reduced and fixed. So screws are good, but you should be able to do them correctly, because the implants are difficult to handle, instrumentation is difficult to handle, and you need to have some training. Can you treat them with just K wires? Yes, I treated this one with just K wires. So it doesn't look like it's compressed. You don't need to compress them. You just need to keep apposition of the fragments and use these wires like you would put in screws, and you can get a fairly good result. If you miss the bus and you have a malunion like this, then you need to correct it. When you go in for correction of malunions, then there's no question. It's better to use a plate. And here's how you do the correction. With the transverse osteotomy, correct it into position, and that's a plate. And there you can see the function, the rotation, the malalignment is gone, the scissoring is gone. There's a bit of flexion that is restricted. So that's how I would treat shaft fractures or fractures in the main part of the bone that does not involve the joints itself. So I would tend to keep them in with intramedullary fixation or interfragmentary fixation, either with wires or screws. And I'd use plates very selectively in some small locations.